Sorry.
So the peripheral IV axis is also an external jugular vein. As you would in a peripheral IV site, you would use your regular IV material. You'd have your roll, your VenaGuard, your tapes, your various sizes of needles, something to connect up to saline lock or an IV bag with your tubing already prepped. Choose your site selection, either the right or left side. When you do so, you have to have the patient's head kind of turn to the direction that you want to start, so you make a level, flat plane. It doesn't matter which side you are, but it does help if you're right-handed. It's a little easier because you have a lot more angle here if you started on this side versus this side. However, this hand can stabilize the patient's neck from rotating backwards when you do the venipuncture. But you're going to be coming in this kind of angle here, or in this type of angle here for right-handers. If you're left-hander, then you would be coming in this angle here, or you're coming in this angle here. Again, we're just trying to look for the site, and then you prep your material. So prepping the materials, make sure you have all your tape. You're gonna need to make a chevron, or you could use the VenaGuard. This we would put somewhere. Get your flush, make sure it's correct, sterile technique. Flush out all the air so that you can have this ready and it stays in the packaging. Alcohol prep. You need a syringe to draw back the blood supply because there's no actual tourniquet that you'll be using. So choose a catheter that's also long, connect up, make sure everything's sterile. Tapes, everything is ready, and then you can have some kind of backup like a 4x4. So I don't see 4x4s there. Gotta make sure you put that in your roll pack. So let's go ahead and turn the patient's head to the side. They can be sitting, but it's easier if they're more of a Fowler's position or semi-Fowler's or supine. This will allow the venous engorgement in this external jugular vein. Tourniqueting the vein would cause a finger here, and then you're gonna strip back the vein. So we can try start it on this side. Basically, you're gonna tourniquet down at the base. You're gonna just pull back so that you can create tension on the vein so that it's taut, that it doesn't run away from you when doing the exertion. Can you see this pretty good in that angle?
I can move it.
Okay. So we find the site somewhere in here. It usually starts just under the jawbone and it'll run down just above the clavicle. And if you start too low, you may have the chance of actually pushing the needle through the vein and into the pleural space, because the collarbone and the apices of the lung is pretty much right there. So if you penetrate through, you cause subcutaneous emphysema. Congratulations that you did your first thoracentesis. But that's not what the event was. We were trying to get a external jugular vein. What we want to do is start high so that when you insert the catheter, it's left up high. And you're far away from the pleural space and the apice on the lung. Also, there's a valve that's in the jugular vein, and if you push up and the catheter rests up against the valve, every time the person's head goes back into a neutral position, the catheter tip is blocked up against the valve and the IV doesn't run. So now every time you have to run the IV, you have to turn the patient's neck, or you have to tape the skin higher so that it's not bumped up against the valve. There may be other types of IV sites or IV needles that you use, not site, IV needle, in which case you're unable to put a syringe on it. The problem is that a flashback chamber sometimes will not readily fill this because there's no real tourniquet and causing that engorgement. Remember, all of this blood supply is coming back from the cranial vault, coming back down from the face and tissues up and above the heart. So it's just draining back downwards. So we may not get this thing to fill, which makes it hard to determine whether or not you have completed the venipuncture. We find the site, rotate the neck, have the person in a position that will cause the venous return. Get your alcohol and your tapes already prepped. Make sure your saline lock and flush is ready to go in a place that you can see it. You're going to tourniquet the lower part, you're going to stretch the vein out, and then you're going to clean the site. You clean it until it's clear. Use that type of wagon wheel. You can relax as long as you remember where you cleaned. Do the preps just like you would with the IV needle. Make sure that everything is nice. There's no type of burrs, spurs, or shears. Tourniquet off the vein again. Stretch out that vein so that you're not in the particular area. Start high, venipuncture straight down, and then 1, 2, 3, poke down. You'll get a flash. Once you penetrate through the skin and you feel that pop, start to draw back. Look at my finger and my thumb on the hand that's against the neck. You want to make sure that that catheter never touches your finger as you rub down or as you try to venipuncture. You contaminate this part, you're putting in pathogens into the patient. Your backhand here on my top hand holding the syringe and the IV needle. I started down low, but I'm gotta be flexible so that my finger can draw back on the plunger so that I know I have blood return. You would advance a little bit more and then separate the catheter. You can move your hands down, separate the catheter so that you know that the needle doesn't penetrate more as you insert your catheter further down. So just run it all the way down. My hands is two-handed technique. You cannot let go of the tourniqueting. You cannot let go of the traction. You can't let go of this hub until you get that hub that situates right against the skin already. So now what happens after I do this, I'm going to relax the tourniquet part, and as I release my top finger that's pulling on the skin, I'm going to allow it to go down together. So this is going with the skin back down. The needle is far out of the catheter, so it's not going to poke in. Now I'm going to have to feel for that catheter tip. Replace my fingers without touching the insertion site over the hub so that I can withdraw the needle and then dispose of this into a Sharps shuttle or Sharps container. Then you go ahead and connect up your saline lock or IV tubing. Again, you're never letting go of this hand, you're just switching places. You go ahead and flush the line and it should run freely. You're looking for any type of extravasation or development of some type of hematoma. If everything works well, you can disconnect the IV saline lock from the flush. That can go into the trash. And securing this, then you kind of secure this around something. You can secure it around the ear, but basically you're going to secure it like this. You can lift up because you're still holding onto it. And you have to figure out how to do your chevrons. I noticed that you guys are having issues with the chevron. It just becomes just a handing, a method of holding the tape in your hand in the position and being able to flexibly move right to left. So you make that chevron that's covered, you place your other tape over, secure that down, and with additional tape, you can secure this around the ear, you can secure it down further around the neck. I'll put more tapes down here so that you can use it. Now the person can go back and you can continue on with management of the patient, intubate them or whatever.